Okay. So invasive hemodynamics. So
دكتور حاتم.
ايوه
دكتور
اتفضل.
حاتم،
ايوه
صوتك بعيد يا دكتور حاتم.
بالله.
ايوه
طيب. How about now؟ احسن.
والله لسه بعيد.
طيب.
لا الصوت واضح، ممكن يكون مشكلة من عندك. تشيك.
يكون عندك تراجع.
ياسين الصوت بتاعي كويس معك؟
الصوت هنا كويس خالص، بس انا عندي كونسيرن انه الدسكشن بعدين في نهايه اللكشر ان شاء الله خلي برضه يكون ريكورد عشان يكون مفيد اكثر
اوكي
باذن
تمام.
الله.
طيب بالنسبة للinvasive hemodynamics what is meant by invasive hemodynamics معناتها hemodynamics derived from or derived invasively in the cath lab. Yeah, that's invasive hemodynamics. How frequent you think we need it now يعني in comparison to what we used to get them or get invasive hemodynamics in the past. طبعا الأمور is so different. يعني before the era of echocardiography, invasive hemodynamics were the main diagnostic tools for in cardiology. ولكن مع الإيكو rarely if ever we need to settle dispute at invasive level. Okay?
كم هو؟
Yeah. Now,
كم هو؟
sorry. As far as
لا
the
لا
as far as the exam is concerned,
لا هو قاعد يقول لي انا الان مثلا قاعد هناك بحضر لي في لكشر والله
just a moment.
بينتظر بحضر في لكشر 1 اور 1 اور المشكله انا المودريتور بتاع اللكشر انا المودريتور بتاع اللكشر ساعه واحده.
طيب, as far as the exam is concerned, okay, uh, the most important of hemodynamics you need to know about is constriction and restriction. In an order of frequency, by the way, that's according to my experience in the exams. Constriction and restriction, who compulse, aortic stenosis, pro sign, waveform, arterial waveform analysis, then MS, MR, TS, MTR, and some few others. Okay? We will go through all of this. الآن, why did I insist on invasive hemodynamics session early on? لأنه it's foundational for understanding of echohemodynamics. And it is also foundation in understanding the pathophysiology of different disease entities we encounter day in and day out in cardiology. So it's important. It facilitates our understanding. It lets us grasp the pathophysiology in a visual way, okay? And that's what we are going to show shortly. Now, the Swan-Ganz, probably you have used it before, is a right heart cath hemodynamics. So it's inserted venously, it goes to the right atrium, then to the RV, then negotiated through the pulmonary artery up until we wedge in the pulmonary artery. And here is the tracing you get. So the first tracing you get is right atrial pressure tracing, right ventricle tracing, pulmonary artery, and pulmonary wedge. And this is the shape of each one, okay? Now, if I put the tracing of the LV superimposed with aortic tracing and arterial tracing, it looks like this. So here we go. You see the LV tracing is this one. I'm following with my red marker. This is the LV, Okay, so this is systole. Sorry, I'm gonna take this one away. Systole, and we come all the way down. This is all systole from here up until here. This is ejection time. So when you look at the ECG, you are in a systolic period. You are in a systolic period. Diastole start here. This is diastole. Okay, ENA. So P is the last stage of diastole, preceded by the early stage, which is here. So we have diastolic part and systolic part. And look at the aorta. What is the difference between, physiologically, what is the difference between aorta and LV pressure tracing? They coincide in the systolic pressure, but they are so different in diastolic pressure. Yani the diastolic pressure of the aorta is start at, let's say, 80, here it is 10. Yeah. فالديفرنس دي مهم جدا. بعدين when you look morphologically at the tracing, you know when you call it arterial tracing, when you call it ventricular tracing. They are similar in the peak systolic value, but they are so different in the diastolic. Okay. Now here again, we have A wave. Look here. A wave, C, X, V, and Y. And this reminds us of venous pressure tracing, the same. It follows the same waves. Jugular venous pressure, A, C, V, A, C, X, V, Y. Yes? A comes from what? A. A is the result of atrial contraction. So from A to X, the pressure goes down. Why the pressure goes down from A to X? Because now the left atrium or the right atrium, like we're going to discuss shortly, is going to be relaxing. So the pressure drops or decline with this relaxation, okay? But this decline in the pressure is interrupted momentarily by the C wave, which increases it a little bit. This C wave is due to what? Anybody knows?
Closure of tricuspid valve.
Sorry?
Closure of tricuspid valve.
If you raise your voice a little bit.
Tricuspid valve closure.
Tricuspid
كلوجر
valve.
اوف تراكن فال كلوجر
طيب closure. Yeah, here طبعا whether we are talking about mitral or tricuspid, they are alike here in terms of A, X, V, and Y. Okay. But I'm talking about the mitral valve. I'm talking about the left atrium. So you mean closure of the mitral valve? Yes, but closure of the closure of the mitral valve by and itself will not lead to this elevation. And the left atrium is what is relaxing. Yeah, well, valve is closed, like it's relaxing. Okay, so I expect the pressure to be or to go precipitously down, but that's not the case because C wave is a sudden elevation. This comes because of the bulge in the annulus backward with systole. Because during AX descent, what do we have downstairs? We have ventricular systole. The ventricle is contracting. So this ventricular contraction is going to lead to backward push into the annulus. So the annulus goes a little bit or ascend a little bit upward, compromising the LA relaxation momentarily leading to C. Right? Okay. Now, what is V? V is what? V, during V, again,
فوليوم accumulation in the atrium.
exactly, yes. But now the venous retain is coming. Yes. So after the left atrium relaxes, it gets blood in. So getting blood in is going to increase the pressure. So V wave is the venous retain that comes to the left or right atrium. It comes to the left atrium through what? Through pulmonary veins. ولكن إذا عندنا right left shunt يعني through ASD كمان ممكن يزيد ال V wave. إذا عندنا mitral regurgitation leading to backward push of a volume of blood كمان ال V wave حترتفع. يبقى أنت think of ال V wave at any blood that comes to the left atrium during ventricular systole or during venous retain period, venous filling period of the left atrium. Okay? And now after that, after the V, خلاص ال V معناتها ال pressure goes high لأنه now the left atrium is full of blood. What happens after that? The pressure in the left atrium is going to exceed the pressure, the diastolic pressure in the LV, and this is going to open the mitral valve and the blood goes down. So when the blood goes down, the pressure in the left atrium drops, and this is Y descent. This is the Y descent. Okay? So the atrial pressure, whether left or right, has A and V ascend and X and Y descent. And you have to know which each one means. Okay? So if you superimpose the atrial pulse or the atrial wave against the LV, you are going to see it this way. So the V wave, where the V wave comes, where the V wave comes. Here, this is the LV. If I go like this is LV. So this arm is a systole. So the V wave is a systolic event. V wave is systole. Remember, this is very important. V wave is systole. And venous return to the left atrium takes place during ventricular contraction. Yes? So V wave is a systolic event. Now A wave is the systolic event. Yeah? This is what you have really to know about. Are we okay so far? جميل.
Yes, good boss.
طيب, how do we measure the LA pressure? LA pressure. LA pressure, we measure it by a direct LA catheter. We can have LA catheter or we can have wedge catheter. So what is the difference between the two? طبعا, it's more commonly we get LA pressure hemodynamics from wedge than from LA catheter. Why? Why? Anybody has an answer? Simply the cost of having LA pressure, direct LA pressure, is that you have to be in the left atrium. And being in the left atrium is much more invasive than having wedge, because how you get to the left atrium? We get to the left atrium through the interatrial septum, so we have to pierce the septum. Okay? Going, في بعض الناس بيقول لك going retrogradely by the aorta, okay? And like bending the catheter back into the left atrium, kind of retrograde. لكن حتى دي invasive. ليه؟ لأنها الكوست حقها إنه we go arterial puncture instead of venous puncture. Okay? ولكن الويدج does not necessitate any arterial puncture. We go venous, femoral مثلا, and then we go to the right side and we negotiate our catheter until we lodge into the pulmonary artery and we check it from there. Okay? We check the pressure from there. لكن in terms of accuracy, now we talk about which one is more invasive. Definitely the direct LA pressure tracing is more invasive than the pulmonary capillary wedge tracing. لكن which one is more accurate?
On the left side.
Exactly. From the left side is more accurate. أول حاجة كمية الارتفاكت اللي فيها أقل. الحاجة الثانية it is more real time. بمعنى what you get in the left atrium is exactly what is happening right now. لكن الوedge is kind of time lag. There is time lag because for the wedge your catheter is in pulmonary circulation and you are checking a pressure in the left atrium. There is a distance. So this time lag has a problem. Yeah, time lag has its problem. And I'm going to show you حتى in the interpretation and analysis, this problem might impose erroneous consideration of gradients and stuff like that. Okay? فهنا لاحظوا معايا ال LA pressure. شوف ال LA pressure. This is direct LA catheter. Direct LA catheter. Look at the pulmonary capillary wedge. Yes? You see? You see? So what is the difference between two? إنه ال pulmonary capillary wedge is delayed. يعني ال pressure هنا you get it directly in real time. هنا there is time lag. There is a time lag. This is a time lag. Okay? So if you time this A مثلا, A wave, if you time it to, or V wave, you time it to systole, it coincides so perfectly well. لما تكون LA pressure. لكن في الويدج no, it doesn't coincide. It comes after the P wave. لأنه في time lag. Okay? Time lag. Okay. Now, if we look at the arterial pulse wave form, this is how it looks like. Okay? So what we have is, with the contraction, that's what we get. Forward wave, reflected wave, and the distance from here to here is the augmented wave. And then we have dichrotic notch. And dichrotic notch is due to the closure of the valve, okay? And then we get the diastolic pressure. So this peak is the systolic pressure. And this nadir is the diastolic pressure. So the systolic and diastolic. So the difference between the two is the pulse pressure. Okay, the pulse pressure. This is the difference between the two. So what is this forward wave and reflected wave? As the blood goes through the circulation, there are reflected waves. These reflected waves kind of augment the pressure. يبقى معناتها this one here is if I cancel this part, what I supposed to get is this pulse like this. This is what's generated by the LV. LV push. But when I record the pressure, what I get is more than this. I get an additional bonus due to reflected wave. As the blood goes through the vessel, waves are reflected, pressure is augmented or amplified. This is called augmentation of pressure. Augmentation of pressure. This is very important, augmentation of pressure. And this is physiological, okay? طيب. Now this augmented pressure, as we know now, the mechanism is just running through the circulation and accumulating reflected waves. Do you think it increases as we go distal in the circulation or proximally? يعني if you check the blood pressure in the aorta and you compare it to a blood pressure in the femoral artery, which one you think is going to be high? Higher. Which one is going to be higher?
Femoral.
Exactly. Why? لأنه as the blood goes and as the distance increases, more of reflected wave, more of augmentation of pressure. So as we go distal in the circulation, the blood pressure rises. Okay? And this is importantly, لأنه هنا نجي مثلا. If I compare the aorta, which is here, sorry, the aorta, and then I'm going distal, brachial, radial, femoral, dorsalis, pedis. You see the blood pressure, the diastolic pressure is decreasing and the systolic pressure is increasing.
Okay.
Yes, it's increasing. This is called peripheral augmentation of the pressure. Peripheral augmentation of the pressure. Okay? Or you can call it peripheral amplification of the pressure, whatever you call it. Okay? So this is important, and this is due to the reflected wave and the augmented pressure due to that. Now, what is the practical implication of this when we come to invasive hemodynamics? Before that, look at this here. If we take a normal waveform, So we know now this is a reflected wave. We know everything. We know this one here is the systolic and this is the diastolic. If we have stiffness, arterial stiffness, the arterial stiffness you think is going to increase the augmentation or decrease it?
decrease.
Exactly. لأنه when the artery is stiff يعني تخيل أنت لما يكون عندك elastic artery. So when the blood moves into it, it molds according to the pressure. So there is no much of reflected waves. Like كل ما يكون stiff pipe, when the blood goes, more of reflected wave لأنه الأورطة is not gonna mold or the vessel is not gonna mold like dilates and relax or dilate and contracts like in a physiological way. It become like a stiff cemented pipe. So the pressure gets more augmentation. So arterial stiffness gets more augmentation. And what do you think arterial stiffness has to do with the diastolic blood pressure? Arterial stiffness with the diastolic blood pressure. It decreases it in comparison to normal. Why is that? Why? لأنه if you look at me here, and I hope my video is clear, I'm showing by my fingers. If that's the caliber of the, let's say the aorta, okay? So when the blood goes in, it dilates. When the in diastole, when the blood flow is lower, it recoils, okay? It recoils. And this recoil determines the diastolic pressure. But if it is stiff, it doesn't recoil. So in diastole, the blood decreases and the diameter is still wide. So that's why the diastolic pressure in arterial stiffness is low. And this is high pulse pressure due to arterial stiffness. So the major marker of arterial stiffness is the pulse pressure. High systolic peak due to augmented wave and low diastolic blood pressure due to the stiffness and the absence of arterial recoil. Okay. Now let's see the practical application of that. So when we have here aortic catheter. Now this is aortic catheter and they are comparing LV and aorta. And like we said, what you should have is a coincidence between these two curves here. So they should not separate in systole. They separate in diastole, physiologically, but in systole, the peak aortic pressure should be equal to the peak left atrial pressure. So if there is a difference, this difference indicates what? In LV pressure is higher than the aortic pressure. So I'm dealing with a case of aortic stenosis. Yes. So this is aortic stenosis. Now, this aortic stenosis tracing here is taken from central aorta and here from femoral. Look at the difference between here and here and here, or let's say this one here and here. Here the pressure is more than here. This is for the same patient. So for the same patient, if you measure the peak-to-peak gradient in a case of aortic stenosis, you get lower figure if you are using femoral artery. Why? لأنه البلس get augmented. هنا الآن أنت when you compare this pulse في البيك و you compare it في الفيمورال هتلاحظ إنه الفيمورال gets what? Amplified and augmented. ولما يكون الفيمورال ارتري اوجمنتد معناتها اذا اعتمدت عليه في حساب الاورتيك ستينوسيس جريدينت هيكون في اندر استيميشن. ولذلك الستاندر في الاستيميشن اوف aortic gradient invasively it is to use a central aortic catheter. ما تعمل femoral catheter ولا radial catheter. اوكي لانه اذا سويت كده هيكون في اندر استيميشن للجريدينت. Why? Because of the peripheral augmentation of the pressure. Okay. Another point when using invasive catheters for aortic stenosis or in general for pressure measurement, we have side hole catheter and end hole catheter. Usually we use side hole catheter. Why? لأنه الاند هول، لاحظ الاند هول. انت الاند هول دي مشكلتها ايش؟ انها easily it can stuck to the wall ويحصل لك damping. لكن السايد wall is sneaky and tricky, hard to stick to the wall, so you can always get pressure. Okay. لكن في الاند هول you might stuck to the wall, you get drifted here and there against the wall, against a leaflet. So damping of pressure, false estimation of the pressure. Yeah. So we use side hole catheter. يبقى الآن from here we know for aortic stenosis in particular we have to use central aortic catheter for not femoral catheter, and we use side hole not end hole catheter. طيب if we look here what do we see? Look, ده هنا femoral artery, sorry, this one is femoral artery, and what is this other pressure is what? Is aortic. See the difference? This is physiological, by the way. See the difference? When you go to the femoral artery, the pressure is much higher than the aorta, significantly higher. So if you use this pressure for aortic stenosis evaluation, you are gonna underestimate the gradients. I hope we get this point clear. Are we?
Yes.
تمام. طيب, now look at the different pulse characteristics. يعني إذا أخذنا this is the normal and this is the dichrotic notch, لما يكون البلس of aortic stenosis بيبقى parvus tardus. ففيه two features. It is small as إنه البيك حقه is lower طبعا than the peak here. And it is tardus as إنه instead of going this way, no, it goes late. So it is delayed small pulse, pulsus parvus tardus. Now in AR, we get this because of the reflected wave. So we get a split or pivot wave form. Now when we have a patient of low cardiac output, low stroke volume, you see the dichrotic notch is gonna be down. And when we have hyperdynamic circulation with higher stroke volume, dichrotic notch gets up. So dichrotic notch can mark يعني the magnitude of the stroke volume by how it moves up and down in the down slope. If it goes down, low cardiac output. If it goes up, high cardiac output. Okay, so this is important when you look at the waveform. You can have rough estimation of the stroke volume just based on the position of the dichrotic notch. Okay. Now look here. This is important. Now, what do we have here? We have mean, this is pulmonary artery. Oh, yeah, I'm sorry. I mixed the two together. Look here. This part, look at it. What do we have here? LV, that's the LV, right? That's the LV. And this is the aorta. So what do we have? We are supposed not to have this gap, right? We shouldn't supposed to have gap. The shaded area physiologically should not exist. Like now we have a gap. This gap is the pressure gradient between the aorta and the LV. So we have a case of aortic stenosis, the degree of which depends on peak to peak gradient. Yani how is the difference between the peak aorta and the peak LV. And also the mean. We can also calculate the mean, okay, in cath lab of all this area. It gives us the peak pressure gradient between the aorta and the LV. The same applies here. What do we have here? This is RV and this is pulmonary artery. So the pulmonary artery is supposed to be here البيك حقه, ولكن الآن في all this difference, sorry. All this difference exists, all this difference, which is peak to peak gradient. So what is the problem here? PS. We have pulmonary stenosis. We have pulmonary stenosis. The degree of which depends on what? Depends on how much of peak to peak gradient we have and how much of mean gradient, which is all this difference all through the period of ejection between the pulmonary artery and the RV. So now you know how aortic stenosis, how pulmonary stenosis look like. Okay, you get this? Tamam. Now look here. Here to the one on the left, this one, to the one here. We have a gradient between the aorta and the LV. Where is this gradient? It's this one. See the gradient? This is all gradient. Okay? So we have gradient. And also I have what? Parvus. Sorry, tardus. Tardus meaning the pulse comes late. Comes late. It's supposed to come here, to rise here like this. Now, pulsus tardus is a sign of fixed aortic stenosis. So this is aortic stenosis. How Hookham looks like? Again, we have gradient between the aorta and the LV, but we don't have the tardus. And we have a morphology which is different. Look at it. If I take it out, it looks like this. They call it spike and dome. Spike and dome. Not doom, spike and dome. Okay, I'm gonna explain why spike and dome comes in Hookham. لكن now you could appreciate إنه الهوكم obstruction والaortic stenosis obstruction, they look alike in terms of the gradient, لكن you have to analyze the morphology. The morphology might give you idea about which condition you are dealing with. If you tardus is more with aortic stenosis, spike and dome is more with Hookham. Okay. Now this is the spike and dome. So this is spike and dome. So I want you to pay me attention here because I need to explain what does it mean to have a spike and dome. Okay, because this is a very important characteristic of Hookham pulse. And you can rely on it confidently to diagnose Hookham just based on this pulse. Okay, if you get that by clinical exam or if you get it in a sample analysis of volume pulse, spike and dome. Whenever you see this one, think of Hookham. طيب يمكن انتم متذكرين انه في الايكو عندنا حاجه اسمها dagger shape signal, which is this one, dagger shape signal. Dagger shape signal, like it here, look here. What do we have? We have like this, and then it goes this way. So what do we have? The velocity. Dagger shape signal is about velocity of the blood. لكن المورphology ده is about what? Pressure. This is pressure. So what happens in Hookham? In Hookham, in mid to late systole, the obstruction gets more. So the velocity هيحصل لها شنو مع الobstruction؟ تزيد ولا تنقص؟
تزيد.
ها؟ ايوه
تزيد.
تزيد. Exactly. ولذلك هنا if you look at the dagger shape, it is composed of two flow. The initially slow flow and the late or mid fast flow. That's why it looks like a slow flow and then fast flow. Why do I say that? لأنه أنت إذا مسكت الجانب السلو التايم حقه أهو ده التايم حقه. أما الجانب الثاني التايم حقه هنا. يبقى it gets faster from this midpoint. عشان كده بيسموها mid to late peaking of velocities. So the dagger shape signal إذا أنت you want to express it in an echo language, here is a mid to late peaking of velocities. That's all. And that's how we see it. Now, معنى ذلك إيش؟ The velocity of the blood in Hookham increases in mid to late systole. And بتكون شنو؟ وبتكون low in early systole. يبقى in early systole velocity is slow, لكن في mid و late systole velocity is fast. Now look at the pressure. Let's translate that into pressure. What is the relationship between velocity and pressure? العلاقة شنو؟ يعني بمعنى آخر السؤال، إذا زادت الفيلوسيتي البريشر بيزيد ولا بينقص؟
حيزيد المفروض.
إذا زادت الفيلوسيتي، يعني إذا في عندي بايب ودخلت فيه فوليوم of water of fluid and I run it slow versus fast, under which condition البريشر على البايب بتكون هاي؟ مع السلو موفينج ولا ولا الفاست موفينج فلويد؟
المفروض مع الفاست.
لا، مع الفاست البريشر حتقل، صح؟ كل ما الحاجة ماشية بسرعة البريشر that it imposes on the surrounding حتكون أقل. يا ليه؟ لأنه في علاقة بين البريشر ما هي الماس، الفيلوسيتي كل ما زادت الماس بتقل. زي ما قال اينشتاين إنه أنت مثلا لو ماشي الآن بسرعة اللايت your mass is zero، يعني البريشر اللي أنت you are gonna impose is kind of zero. يا فكل ما أنت you slow البريشر حقتك بتزيد for the same mass، وكل ما you move faster for the same mass البريشر حقتك حتقل. يلا معنى ذلك انه early الفيلوسيتي is what هنا؟ الفيلوسيتي is what؟ is low. Look at it early pressure، البريشر early is high. Now في الميد والليت الفيلوسيتي is high. Look at the pressure في الميد والليت it's low compared to the initial part. Yes, so this is equivalent to this. This is only in velocity term and this is in pressure term. Like it's the same mechanism. So why do we get a spike and dome? Because the initial velocity of the blood is fast, is slow, therefore the pressure is high. In mid to late systole, the velocity of the blood is fast, therefore the pressure goes down. عشان كده بيكون في high part و low part in term of pressure. And that's what makes a spike and dome. Spike, high pressure, and the dome of the low pressure. Spike and dome. Okay? Do you get this?
ايوه ايوه
Okay.
ايوه.
تمام. Now look here. This is very important signal, extremely important. So what we see here is what? We have a gradient. If we follow this gradient between the LV and aorta, LV aorta, LV aorta, so I have a gradient. This is probably, this gradient might mean what? It might mean aortic stenosis. It might mean Hookham, right? Right? Yes. Now we have a PVC. After the PVC, look at the gradient after the PVC and compare it to the baseline gradient. Does it increase or decrease or remain the
increase.
same?
increase.
Huh?
increase.
Why does it increase?
Because the pressure in the LV increased after the PVC.
Why?
Increasing in the volume.
exactly لانه بعد البي في سي في بوست بي في سي بوز. البوز ده ال في بيكون in diastole is filling with blood، فالبلد بيكون فيه الفوليوم بيجا هاي، فلما يفتح الفالف البريشر حتزيد لانه في more volume you have to push through the valve. تمام؟
ايوه.
تمام. Look at it here. Now look at the other patient. We have a gradient which remains like the same. And then we have PVC, after which we get a gradient that has increased also for the same reason, because of increased volume post PVC pose. Okay, so we have this one. طيب. So now this looks alike. We have a gradient and which increases after after PVC. لكن if I tell you أنه this is aortic stenosis and this is Hookham with high degree of confidence, can you tell me why? What is, if you look again thoroughly and carefully, what is the biggest difference between these two?
The shape or the morphology.
The morphology, yes, ممكن to some extent، لكنه ممكن somebody might argue it's not clear they look alike، يعني ما شايف فرق، لكن في striking difference.
البريشر difference between
Thank you
الاورتيك
so much.
stenosis
طيب
والحكم في الحكم it is more increased.
أيوة، يبقى pulse pressure. Look at the pulse pressure. Look at the pulse pressure here. What happens to it? It widens compared to the baseline. Look
Yes.
at the pulse pressure here. It shortens compared to the baseline. This is called Braunwald-Moro sign. Very important diagnostic sign of Hookham. What is it about? It's basically about this. The most important description about it is this one. Number one. Decreased arterial pulse pressure. This is Broken-Bro. Now, increased systolic peak pressure بيحصل، لكن does not distinguish between AS and Hookham لأنه فيهم الاثنين بيزيد. الحاجة الثانية سبايك اند دوم، زي ما الدكتورة قالت إنه سبايك اند دوم ممكن يظهر أكتر بالذات بعد البي في سي. Look at it هنا، it looks like spike and dome. لكن هنا ما في الشكل بتاع spike and dome. لكن what is the most important description of Braunwald-Moro sign is the decrease of arterial pulse pressure. لأنه إذا البلس pressure widens, that is true aortic stenosis or fixed aortic stenosis. If it shortens, that is Hookham. تمام؟ فهذا الفرق الأساسي بيناتهم. طيب look at it here again. مثلا هنا في pressure gradient، في pressure gradient، في pressure gradient. Now we have PVC. After PVC, we have increased gradient. لكن most importantly, look at the pulse pressure and compare it to the baseline here. It's taken to you. That's the baseline pulse pressure, and this is the pulse pressure after the PVC. So it gets
Decrease.
shorter.
Thank you. Shorter, yeah.
So this is what? This is
Hookham.
Hookham. Very good. تمام. Now, you remember in a patient of low ejection fraction with low gradient aortic stenosis, and you don't know if this is a true severe aortic stenosis, which is masked by the low flow due to low ejection fraction, or I don't have this condition. This is one of the questions we ask ourselves a lot, and this is called low flow, low gradient aortic stenosis. This concept is important, especially we are going to elaborate on when we come to aortic stenosis, which is low flow, low flow, low gradient AS. And look at this statement, low flow, low gradient. Why they are interconnected? Because الجريدينت is a function of the flow. زي ما هسه ورينا انه في الهوكم بعد البي في سي وحتى في الاورتيك ستينوسيس بعد البي في سي الجريدينت بيزيد لانه we have more of flow. يبقى الفلو بيزيد الجريدينت. طيب اذا عندنا low ejection fraction معناتها low flow and contractility is low معناها الفلو is gonna be low. يبقى that might lead to low gradient. يبقى معناه ممكن يكون عندنا severe aortic stenosis but we fail to get a gradient mean of 40 because of low flow, because of low ejection fraction. It happens a lot. It's an entity called low flow, low gradient, severe aortic stenosis. So in this case in echo, what do we do? في الايكو بنسوي ايش؟ عشان نعرف هل is it
فلسافة
truly
منوبة.
severe؟
فلسافة.
لا فلسافة ما بتفيدنا. أنا بتكلم عن true aortic stenosis not هوكم.
عملت فيتامين ستريس.
Exactly. بنعمل دوبيتامين، لو دوز دوبيتامين، اللي هو بندي دوبيتامين بحيث انه الفانكشنز بتاعت الدوبيتامين ايش؟ we need انه to augment the flow بالدوبيتامين. when we augment the flow we are gonna augment the gradient. So we are looking after inducing high gradients, okay, to confirm our suspicion of severe aortic stenosis. So if we fail to generate this high gradient معناتها ممكن ما يكون truly severe. طيب we can do the same in cath lab. Look here, this is a patient of low ejection fraction and the pressure gradient is here, it's 28 mean, and the area is calculated to be 0.7, okay, 0.7. ف 28 does not qualify for severe aortic stenosis, ولكن an area of 0.7 qualifies for severe aortic stenosis. So is it truly severe ولا is not truly severe? I need to know لأنه it has an important impact on my management. So they give dobutamine, that's in the cath lab. They give dobutamine. Look at the gradient change. Now the gradient is 42 mean. What is the area? 0.7. What's the meaning of that? I have truly or true severe aortic stenosis. Because with augmentation of the flow, I managed to induce a gradient of 40 and above. And the area remains the same. So this is true aortic stenosis. True severe aortic stenosis. Look at the flip side. This is a patient of a gradient of 22, an area of 0.7 with low ejection fraction. They gave dobutamine. What they get? The pressure gradient doesn't move a lot, 24. But the area opens up. So what's the meaning of that? What's the meaning of that?
This
Not severe aortic
هي
stenosis. They call it pseudo-severe. Yani what you were seeing here of area is pseudo-severe. It gives you impression of severity, like when you come to the dobutamine, it opens up and the gradient failed to rise, meaning this is not true severe aortic stenosis. So the same of what we do in echo, we can do in cath lab. Yes, the same. Okay, I will skip this. Now look here. This is LV, that's the LV, and this one is the wedge. Okay, and now this is the same patient, LV and LA catheter. طيب, what do we have here? في gradient. Look at this gradient. الgradient موجود فين؟ موجود بين ال LV diastolic pressure, which is here, and the pulmonary capillary wedge pressure during diastole. This one. This is pressure difference, not supposed to be present. Okay? So what does that mean? Mean I have mitral stenosis. If I have a pressure difference in diastole between the left atrium and the LV, معناته I have mitral stenosis. The degree of which depends on this area. يعني إذا كان هنا versus إنه يكون هنا، معناه هنا more severe than إنه يكون هنا. Yeah, okay. المهم I have mitral stenosis. الgradient, mean gradient evaluated, it is 15. Now when they used left atrial catheter, they check there is still mitral stenosis لكن تحسبه أقل خالص. البريشر gradient is 6. Pressure gradient is 6. So this is the same patient and we are getting a mean pressure of 15, and with the use of LA catheter we are getting a pressure of 6. Who can explain this difference? Why we get this robust difference for the
maybe
same
the tip of the catheter is lodged in the wall of the pulmonary or the pulmonary wedge.
طيب catheter position wasn't so proper. What else?
And the delay del cord.
Sorry?
the delay when taking the wedge pressure different between the recording wedge pressure is still direct, while the LA is direct and there is a delay.
Exactly, exactly. That's what we have discussed earlier. الويدج pressure is late. يعني what we are measuring هنا حقيقة is non-physiological. What we are measuring on this, it's non-physiological. Yeah? ليه non-physiological؟ لأنه الويدج بيجي late. فأنت يفترض تحركه شوية in your mind backward. لما تحركه backward you mitigate this gradient. لكنه هو يتحرك forward لأنه delayed. لكن لما يكون physiological بيكون شكله كده. فبتلاحظ انه الجريدينت is not high. لكن الويدج لانه late بيكون كده، بيجي كده شكله. فيبقى في شكل كبير بتاع gradient. ولذلك when you are measuring for mitral stenosis you are using wedge. Be careful about this time lag لانه عندها impact على ال accuracy of your measurement a lot. ولذلك you have to be wary of this. Okay, and you correct for this time delay. Okay, تمام. Now
طيب دكتور حاتم السمين ذات
ايوه.
يعني الايكو مور اكيوريت
مم.
الايكو مور اكيوريت
هو يعني هنا شويه هو الايكو طبعا في الاكيرسي في الجريدينت برضه عنده مشاكل. برضه عندنا مشاكل بتواجهنا هنتكلم فيها. فصعب انا اقارن لك بين البريشر جريدينتس اللي نحن we obtain in cath lab versus what we get in echo. اوكي، لانه كل واحده عندها its own limitations. اوكي، لكن اقدر اقارن بين الويدج درايف بريشر and LA catheter drive pressure in mitral stenosis. عارف انه هنا accurate هنا inaccurate because of time lag and stuff like that. اوكي تمام. طيب في بعض الاحيان يا شباب we exercise patient of mitral stenosis. حتى حسب الجايد لاينز you can exercise patient of mitral stenosis. طيب who is this patient and what is this patient? What is the quality of the patient you elect to exercise وهو عنده mitral stenosis؟ ذاك
when the
البيشنت.
يعني measurement is not correlated with the system.
Exactly. يبقى عندي clinical data and echo data are not matching. طيب in what way? In what way؟ يعني
يعني لو كان العيان عنده measurement of severe aortic stenosis او mild او mitral stenosis والعيان asymptomatic لا يعني العيان symptomatic والميجر سمايل.
very good very good exactly. يبقى إذا البيشنت symptomatic مثلا لكن الإيكو fail to elicit high gradient to explain symptoms of this patient, I'm going to exercise this patient. Okay, looking for what? For إنه exercise might going to induce higher gradient. فبالتالي now I'm going to get symptoms echo match. A patient is going to be symptomatic during exercise. At the same time, we're going to elicit higher gradient. So I'll be happy, confident إنه this is severe mitral stenosis and it's the cause of his symptoms or her symptoms. طيب, look here. This is a patient of mean pressure of 8 and wedge of 18 at rest. So he is exercised. Okay, he is exercised. طيب, when he was exercised ايش اللي صار؟ الوedge is 41 and the mean is 29. What do you think? What do you think? Is it severe mitral stenosis?
No, it's severe.
Exactly, it's severe mitral stenosis. That is severe mitral stenosis. So what's the point here? The point here is إنه الexercise hemodynamics is not exclusive للإيكو فقط. You can do it في الكاث lab. You can do it في الكاث lab. Okay? bicycle ergometer or stuff like that. You exercise the patient while you are measuring pressures. Okay, فهنا the move of the pressure from 8 to 29 and wedge from 18 to 41 indicates severe mitral stenosis. Okay, now look here. This is again, this shaded area is mitral stenosis gradient. And now look at the shaded area has decreased a lot, after mitral valve balloon valvoplasty. And this is important. يعني مرات لما يكونوا بيعملوا في البالون valvoplasty, they check the LA pressure. Already they can have a catheter في left atrium. ليه؟ لأنه they are already in the left atrium. So they can use direct LA catheter, which is more accurate than wedge. So they can evaluate the gradient before and after. Okay. And here again, look here, the mean mitral was 15, post ballooning it is 3. And the area was 0.6, post ballooning it's 1.8. Great achievement. Okay. Again, here, if you look at the black shaded area before the procedure and how it transformed after the procedure, robust decrease in the mean gradient. And this is the ballooning. You see the ballooning? This balloon is called Hanoi balloon, Hanoi. So what they do is, look at it here in the video clip. Look at it. So what happens is what? أول ما يدخلوا البالون بيدخلوها into the LV, okay? And then they inflate the LV balloon and they drag it backward. So that LV balloon is gonna be just below the mitral valve. And now they open the second balloon or they inflate the second balloon. Okay. السكند بالون حيكون بالضبط وين؟ في حتة الميترال valve is going to split the mitral valve apart. You see? So الشكل بتاعها بيكون هنا، الميترال valve بيكون بالضبط هنا، مكانه هنا. فthis part في ال LV و this part of the balloon في ال left atrium. لكن they inflate the LV balloon commonsensically first to incarcerate the balloon against the mitral valve, and then they inflate the proximal balloon. Okay? تمام. طيب. Now look what we have here. Restrictive cardiomyopathy and constrictive pericarditis. What is this? This is LV, RV pressure tracing. We call it simultaneous because they are taken at the same time with two catheters. Just a moment. طيب, are you following me يا شباب؟
Yes.
تمام. طيب, هنا we call it simultaneous, meaning taken at the same time. لأنه في catheter تاني بيسموها pull back. Pull back معناه you have only one catheter بتعمل بيها هنا ثم بتطلعها إلى هنا ثم بتطلعها. ده اسمه pull back tracing, one catheter. لكن this is not pull back tracing. This is simultaneous. You have two catheter recording at two different locations at the same time. So we have LV and RV catheter. Now look at the difference. Look at the difference here. The pressure is high of the LV is high here and the RV pressure is high. The LV pressure is low and the RV pressure is low. So what do I have here? I have LV RV pressure concordance. They go up together and come down together, concordance. Now look here, what do we have in here? Look, when the LV pressure goes high, RV pressure goes low. When the LV pressure goes low, RV pressure goes high. So what do I have here? I have LV RV pressure discordance. Discordance. So this discordance is the hallmark of constrictive pericarditis. Whenever you induce it in cath lab, معناته this is constrictive pericarditis. As simple as that. Okay? يبقى بالتالي لما يكون عندنا patient طبعا usually الكونستريكتيف pericarditis is diagnosed في الايكو، ولكن في بعض الاحيان cases ما ممكن تكون ما clear due to image quality، حاجات زي دي نودي البيشنت فور كاش عشان just to induce the discordance، نشوف هل في discordance ولا لا. إذا في discordance that is constrictive. طيب. Now the question is, why do we have discordance in constriction? Why? Why? Why do we? Sorry? Come again? طيب.
ريجيد بريكارديا الفيلينج بتاع البوست فنتريكل.
أها. Again. You are so close. طيب انا اسهلها لكم، انا عايزكم يعني دايما النولج حقتكم، لانه الكارديولوجي is vast knowledge، very vast knowledge، فدايما خلوها تكون مرتبة in your mind in حاجات big statement, then the detailed statement comes next. يعني مثلا إذا سألنا واحد في الامتحان why do we have discordance in constrictive pericarditis، بدأ يشرح عن تفاصيل انه بيحصل هنا during inspiration ده ايش هو. It's okay. لكن I will mark him better or her better إذا بس قال لي two terminologies أو two words: interventricular interdependence. إنه in constriction we have increased or enhanced or augmented interventricular interdependence. إذا قال كده enough. يلا بعد دي what does that mean in terms of exact mechanism and try to explain it حاجة تانية. لكن خلونا نتذكر إنه in constrictive pericarditis we have enhanced interventricular interdependence. Enhanced interventricular interdependence. يعني شنو interventricular interdependence؟ إنه we have the LV like this and the RV and the septum is in the middle. Okay? Usually they relax and they contract. They depend on each other to some extent. But when we have constriction, meaning the heart is limited to expand outside because of constrictive pericarditis, it depends on the septum really so much. And the 2LV is starting to compete on the septum, and they are in fierce competition, as in when one fills, the other one underfills. When the other fills, the other underfills. Yeah, this is enhanced interventricular interdependence. يعني the filling of one ventricle comes at the cost of underfilling the other ventricle لأنه limited expansion. okay? ولذلك يحصل ده. طيب فبالتالي وبعدين طبعا لما نيجي للبريكارديال disease we are going to elaborate on that further. Again, look at it here. Look here. Sorry, I'm going to get the pen again. So in constriction, you look when we have during inspiration, in particular, during inspiration, RV pressure increases. right? During inspiration, RV pressure increases and the LV pressure decreases. While during expiration, the LV pressure increases and the RV pressure decreases. So this is discordance of constriction. While in restriction, we have concordance. They go up together and come down together. Okay? And this partially explains it. Look at the septum in constriction. This is the interventricular septum. Look at inspiration. This is inspiration. This part of the spirometer is inspiration. So during inspiration, what happens to the septum? It goes what? Toward the left side. So when it goes toward the left side, this part fills with blood. So the pressure is going to be high. Lacking, what happens to the pressure on the left side? During inspiration, it's gonna be low. Yeah? Now during expiration, the septum goes rightward. So this part fills with blood. So its pressure is going to be high. Lacking, look at the LRV. RV is gonna be small cavity and hard to fill with blood. So the pressure فيه هيكون شنو؟ low. And that's the discordance. Look at the discordance. When one increases, the other decreases, and vice versa. Okay? Because now the two ventricles are competing against the septum. Okay? That's what
Yes.
happens in constrictive pericarditis. طيب. Look here again. This is again a constrictive pericarditis. But my focus here is not about concordance and discordance, but about this part. This part. This part, does it remind you of something? They call it a square root sign. Square root sign. Because it looks like square root, right? Like square root. Or sometimes they call it also not spike and low, dip and plateau. Dip and plateau. Yani there is dip, like this, and then a plateau. Yeah, dip and plateau. So whether it is called the square root sign or dip and plateau, it's the same. Okay. What's the meaning of this? It means like, why do we get this dip? Because of Y descent. Okay. And in constriction, we have that Y descent and very high diastolic pressure leading to this. Okay. So you get this one. And the other thing is that when you look at the LV and RV pressure in diastole, they are kind of equal. اللي هو بيسموها equalization of the diastolic pressure between the two ventricles. لكن احنا عارفين انه right ventricle diastolic pressure is higher than the LV. لكن في الكونستريكشن لانه بيجوا under the same influence الdiastolic pressure حقتهم بتكون equal. In restriction, no. The LV pressure, diastolic pressure is still higher than the RV diastolic pressure. So بالتالي when you are looking for constriction, بالذات if you want to distinguish it from restriction, it's not only the matter of concordance and discordance, but also you look at the diastolic curve. If there is a square root sign and if there is equalization of the pressure between LV and RV of diastolic pressure, this is more in keeping with constriction than restriction. Okay? طيب. Now look here, just again, one last time at this part. Here. This is CVP. Look at the CVP during expiration and during inspiration. What do you notice? What do you notice?
Increase in pressure.
Normal.
Exactly. Yes. Yes. Increase during
Aeration.
Inspiration.
Yes,
Inspiration. It's very
exactly.
important, sir.
So what is this? Increase in CVP during inspiration. What does that mean?
I think it's yeah, tamponade or
Or
also constrictive pericarditis.
exactly. And this sign has a name, which can be elicited حتى clinically. What is the
Yes.
name of the sign?
Cosmo sign.
Cosmos.
Exactly, this is Cosmo sign. Okay, this is Cosmo sign. Okay. لأنه اللي بيحصل عادة كيف؟ إنه يكون البريشر عندك during expiration كده during inspiration it goes down بالعادة لأنه during inspiration ال LV relaxes more blood comes become more accommodated the pressure begin لكن كون we have during inspiration increase in the pressure that means we have a real problem of constriction. Okay, so this is Cosmos sign. Now look here. This is an LV, this LV. And here is the wedge. لكن look at the V wave of the wedge. احنا قلنا الويدج فيه V wave. ال V wave تعرفها كيف؟ بعد ال T wave. طيب. Is this V wave normal?
No,
It's
it's
not
very high.
normal at all. Very high. What does that mean? High V wave in the wedge tracing.
At that level, it is not true. It's not very high.
MR
MR. MR. Very good. This is MR. Yes. Not only MR ولكن severe MR. So when the V wave reach this height, this is severe MR. حتى مرات بيسموها ventricularization of the V wave. Ventricularization ليه؟ لأنها بقت approaching the LV pressure. Ventricular. It's supposed to be هنا small تكون صغيرة هنا. الآن see how it reach V wave. وتتذكروا إن إحنا قلنا ال V wave is a systolic event due to venous retain. يعني ال LV is contracting وال left atrium is filling with blood. Now when we have MR, it's a source of filling of the left atrium. فبالتالي ال V wave بتزيد due to that. The magnitude of the elevation of V wave correspond to severity of MR. So this is severe MR, this is ventricularization of the V wave. Again, look here. This is less than ventricularization, لكن still the V wave is high. This is also severe MR. Okay, this is severe MR. يبقى the marker of severe MR in hemodynamic is the V wave. Okay. Look here. Now, طبعا مرات الانفيسيف hemodynamics بقت used أكثر من الأول. ليش؟ يعني نحن قلنا انه الايكو ريبليس الانفيسيف هيموداينامكس لكن الان في ريفايفل ليها لانه بقى في structural heart intervention. They are already having catheter in there and they are doing a procedure like ballooning and clip and whatever, so they can measure the pressure على طول. تمام. فمثلا هنا هذا البيشنت عنده severe MR. What is the marker of severe MR? ال V wave. Look at the V wave. This the V wave. So بياخدوا ال V wave at baseline. مثلا let's say قالوا 50 millimeter mercury. That's the V wave. قام عملوا كليب. بعد الكليب شوف ال V wave. بعد السكند كليب that's the V wave. So ال V wave نزلت let's say to 15-20. So that's great reduction of the MR. Yeah, great reduction of MR. So they follow the MR changes with according to the V wave changes. Okay. هنا مثلا again this is V wave وهنا هذا البيشنت كان عنده severe paravalvular leak وعايزين يعملوا له occluder device. Okay. فهنا ال V wave كانت 50. عملوا closure, it didn't work, it's still 50, it's still high. لكن لما maybe they have put more than one occluder device, it decreased to 20 plus. So genuine reduction of the MR or the paravalvular leak according to the V wave. وطبعا انت لو كنت بتعمل بالايكو simultaneously echo guided, you would appreciate انه في significant reduction. يبقى معناته during the procedure you can check by echo and you can check by invasive hemodynamics and you can check by both. Okay. تمام. طيب عشان ما ازعجكم كثير ولانه I still have quite lengthy part about hemodynamics, وخلينا السكند portion of it نعطيه سيشن تاني. تمام. لكن it's important انه انا الان اتاكد منكم انكم قدرتوا تفهموا الجزء ده بشكل so well. Okay, so I'm gonna stop in here. I'm gonna stop the recording. If you have any questions, just a moment.